Good afternoon. Thank you, Duminder, for inviting me to do this talk. It's nice to talk to you after a long time. Uh, in a way, it's good that I cannot see anybody sleeping. So we are going to talk about three patients who were diagnosed as having Takayasu arthritis, but they were not usual because their response to the initial uh, treatment strategies didn't work. So we'll first start with the first patient. Is Mr. J. He's a 19-year-old A-level student. He has been having episodes of prolonged fever of 5 weeks duration. This he has noted in April 2019. He came to us in September 2019 with left shoulder pain, left arm claudication, with some constitutional symptoms like loss of appetite and loss of weight. He had chronic unilateral headache, but there was no visual disturbances or jaw claudication. The rest of the inquiries were unremarkable. His past medical history to, was unremarkable. When we examined the patient, his brachial and radial pulses was lower than the right one. There was a discrepancy in the blood pressure. The right side, it was 120 by 80. The left side, it was 104 by 58. We heard a bruit over the left carotid artery, and the temporal artery pulsations were present. The shoulder examination was normal. With the investigations, like we saw normal full blood count with rapid ESR at 72 and an elevated CRP at 85 with normal liver enzymes and fasting blood sugar. So obviously that we wanted to do a CT aortogram. The CT aortogram that was done in September 2019 showed left subclavian stenosis. The diagnosis was very obvious. So it was a case of Takayasu arthritis. We started him with prednisolone 40 milligrams daily with methotrexate 7.5 and folic acid. Uh, as a routine, we did a vascular surgical referral, and their uh, plan was to manage him medically. Free, and we have increased his methotrexate to 10 milligrams, and prednisolone was reduced to 35 milligrams daily. CRP was 5 milligrams, and however, his uh, liver enzymes were elevated. ALT was elevated at 143 and AST was marginally elevated at 45. We took gastroenterologist's opinion and they did some more investigations, said induced transaminase, and we were asked to stop. Once the liver enzymes were normalized, azathioprine 25 milligrams was commenced with prednisolone, the same dose, 35 milligrams daily. In early November 2019, he was symptom free, but there was a difference between the blood pressures, and his ALT was 52 with AST was 34. CRP was normal at 3 milligrams per deciliter. Further reduced his prednisolone to 25, and azathioprine was increased to 50. In December 2019, while he was on prednisolone 25 milligrams daily with azathioprine, his he developed a very bad transaminitis with ALT and AST both elevated. The bilirubin was normal. Total protein was normal. Again, we referred him to gastroenterologists. They excluded other causes of hepatic enzyme derangement, and the conclusion was drug-induced liver injury, and we were asked to stop azathioprine. At that time, his CRP was 4 milligrams per deciliter, and he didn't have much symptoms. However, as we were stopping azathioprine, we increased his prednisolone to 40 milligrams daily. In late December 2019, he came back with upper limb claudication. The right side blood pressure was 110 by 70, left side 100 by 6. There was a new right side subclavian drooping, and his CRP was elevated at 28 milligrams per deciliter. And we repeated his CT aortogram that showed right subclavian and axillary arteries stenosis, and it was tortuous with focal dilatation of the right common carotid. Not sure whether this is very good picture, but you can probably see the right subclavian stenosis and proximal left side subclavian stenosis. And our impression was a major relapse of Takayasu arteritis. And we have started him with a methylprednisolone pulse 1 gram daily for 3 days and continue with prednisolone 40 milligrams daily. Despite this, his symptoms continued with elevated ESR and CRP. Oh, I mean, we had no other options. Like, so he was, his parents and the patient was very excited about the condition, and he was like clinically did not look well. We decided to start him with IV tocilizumab at a dose of 8 milligrams per kilogram. And at the same time, we got the vascular surgical referral as well. And they were in the opinion that we should manage medically. The follow-up, the 1 month after the first dose of tocilizumab, symptoms improved and CRP was 3.7. The second dose was given in the first week of March 2020. Unfortunately, due to the prevailing condition, he was not able to come to clinic in April 2020. And third dose of tocilizumab was given in third week of May. At that time, his CRP was elevated to 35, but fortunately, no aggravation of symptoms or signs. We continued prednisolone 10 milligrams daily. So that was our first case, and the second one is Miss D. She was a 34-year-old female when we saw her. She was single at that time. She has been having neck pain of 6 months duration with upper limb claudication and low-grade fever. She had no syncopal attacks. When we examined her, pulse rate was 80. Her volume was less in right side than the left side. The right side blood pressure was 180 by 80. With left side blood pressure was 160 by 80. So there was a 20 degree of difference between two sides. The systolic blood. There was a left side carotid and a left side subclavian bluish. Her ESR was rapid at 59 and CRP was high at 12. Full blood count, the hemoglobin was low with at 9.9. Liver functions were normal. Her ANA was negative. A 2D echo showed an ejection fraction of more than 60% without any primary hypertension or valvular lesion. Ultrasound abdomen was normal. This picture is not very good, the CT aortogram, but it was reported as bilateral common carotid artery and left subclavian diffuse nerve. Again, the diagnosis was obvious, so it was another case of Takayasu arteritis. So we started her on with prednisolone 50 milligrams daily, with methotrexate 7.5. To control her blood pressure, we had to start enalapril 5 milligrams twice a day as well. We got the vascular surgical opinion as well. 2 months later, her ALT and AST were on the rise. AST was 72, ALT was 296. Again, we sought the gastroenterologist's opinion, and they asked us to stop methotrexate because the damage was due to methotrexate. Continued prednisolone 45 milligrams daily. Liver functions normalized after 2 weeks of omitting methotrexate, and we commenced azathioprine. 3 months later, again she developed a transaminitis with ALT 87 and AST 61. Again, we had to take the gastroenterologist's opinion, and they asked us to stop azathioprine because it is most probably due to azathioprine. And by that time, she was on prednisolone 25 milligrams daily, and we started her on with mycophenolate mofetil and increased to 1 gram twice a day. During the follow-up, she became symptom-free, and inflammatory markers came down to normal. MMF 1 gram twice a day continued, and prednisolone tailed off to 5 milligrams over 2 years. However, during these 2 years, she had ups and downs, but she never had a major relapse. In September 2019, she came with arm claudication with right side blood pressure 160/100, with left side blood pressure 148. Her ESR was 45 and CRP was elevated at 38. CT aortogram showed large vessel vasculitis involving arch of aorta, brachiocephalic trunk, left common carotid artery, and left subclavian artery. Then so we manage it as a major relapse with prednisolone 50 milligrams daily with mycophenolate mofetil 1 gram twice a day. However, yeah, again, we sort of discussed about this about with the patient as well as our colleagues, and then we started her with tocilizumab. Response to tocilizumab. After 2 doses of tocilizumab, she became symptom-free, and inflammatory markers reached the baseline. And now she's on prednisolone 10 milligrams daily with MMF. We didn't see her after this break. However, we hope she is doing well, but we have given her, we have contacted her over the phone, and she probably will come to our clinic soon. Our third patient is C. She's a 16-year-old student who had low-grade intermittent fever on and off for 5 months duration with constitutional symptoms. Later, she developed anterior neck pain and she had no claudication or syncopal attacks until it left 100/60. There was no pulse deficit. There were bilateral carotid bruise with right subclavian bruise. A full blood count showed a low hemoglobin. ESR was rapid at 120, and CRP was elevated at 77.5. Liver functions were normal. ANA negative. TB and septic screen were negative. Ultrasound scan, neck and duplex showed luminal narrowing of bilateral proximal common carotid arteries, and 2D echo ejection fraction was normal. There were no valvular defects. CT aortogram showed circumferential mural thickening with mild contrast enhancement of aortic arch descending thoracic aorta up to the level of renal arteries. No aneurysmal dilatation or significant stenotic areas involving the entire aorta. Luminal thickening in brachiocephalic artery and left common carotid. There was luminal thickening. Pulmonary and renal vessels were preserved. This is the picture, but I don't think it shows much of the narrowing because it is mostly intraluminal. And we again started all with prednisolone 40 milligrams daily with methotrexate 10 milligrams weekly, and vascular referral was done. 10. However, she to develop transaminase AST46 with ALT 101, and prednisolone was continued at a dose of 40 milligrams daily. And we again had to take the gastroenterologist's opinion, and we were asked to stop methotrexate. During the next month review, she was asymptomatic with CRP 8 milligrams per deciliter and normalizing AST and ALT. We commenced her on with mycophenolate mofetil 500 twice a day with prednisolone 35 milligrams daily. 1 month later, she is on prednisolone 30 milligrams daily with MMF 1 gram twice a day. 3 months later, while on prednisolone 25 milligrams daily dose with MMF, she developed neck pain, low-grade fever, and systolic blood pressure difference more than 10, around 10 millimeters of mercury, with bilateral carotid artery bruise, with elevated CRP at 37 and ESR at 76. So we manage it as a major relapse with prednisolone 40 milligrams daily. MMF increased to 1 gram mane, 500 milligram noon, and 1 gram nocte. Symptoms improved, but CRP is still high at 17 milligrams per deciliter. We have not done anything afterwards because this happened in February or early March. So we are planning. We are going to see her soon, and whether to give biologics or not is doubtful. We are still not have taken a decision. So in summary, all three patients relapsed when we tried trailing off steroids. First and second patient developed transaminitis for methotrexate and azathioprine. Third patient developed transaminitis for methotrexate. Obviously, like it is not only the tailing of steroids, but we were not able to continue steroid sparing because of the transaminitis they developed. So take a look at the timeline. This is the case number 1. So the symptoms started in April 2019, and we saw the patient in September 2019. And the patient was on prednisolone 30 plus methotrexate, developed transaminitis. And then we converted to prednisolone plus azathioprine, again transaminitis. Then only we decided to give him tocilizumab. The patient 2, he was first diagnosed in July 2016, and we saw her March 2017. She was started on prednisolone and methotrexate. She developed transaminitis for methotrexate, and then we have started on with azathioprine, again transaminitis, and then she was started on prednisolone plus MMF, but she developed a major relapse with continuation of her symptoms, and therefore we started on with tocilizumab. The third patient, we have started her on with prednisolone 40 with methotrexate in September 2019 and developed transaminitis. Again, she was given azathioprine and transaminitis, and now she is on MMF, and we are waiting to see how how her disease is getting controlled. So our problems are, one is definitely a compliance to steroids. We don't know whether they are taking, because they hear horrifying stories about steroids, and they are young people, and they are worried about their body image and all that. They know when they take high doses of steroids, they put on weight and all. The patient number 1 is doing A levels and going back to school, and he would like to go back to school and go to his extra classes as soon as possible. Patient number 2 is like recently got married and is asking for us about the possibility of making a family. The third patient, she too likes to go back to school and to go for competitive sports she has been doing. And the other important issue is the patient and caregiver awareness of the condition. It is very difficult. Like, it is not like rheumatoid arthritis. We don't see anything outside. It's the symptoms, and we have to sort of explain, and we have tried it many times, but sometimes it is difficult to tell them what is happening inside. So it's for you. Think about it. Thank you. And I hand over now to Dr. Surendra Silva to continue with the management.
Thank you, sir. I would like to consider as a privilege to present in this forum and the first webinar of the college. I would like to thank the college for giving me this opportunity. So I will be talking about the management of osteoarthritis. My objectives in this lecture would be to describe the diagnostic approach to Takayasu arthritis, to describe the epidemiology of Takayasu arthritis and to evaluate the common present symptoms and to discuss about the recommended imaging modalities and to discuss the management options available for Takayasu arthritis. As uh, as you all aware about the vascular tree and Takayasu arthritis falls under large vessel vasculitis. So I'm not going to talk about talk in detail about it. And this is the 2012 Chapel Hill Consensus Conference nomenclature about the vasculitis. You all can see that the Takayasu arthritis falls under the large vessel vasculitis category. So, according to the definition of 2012 Chapel Hill Consensus Conference, it's an arthritis involving the branches of aorta, which is of granular matters in nature, and the onset is of less than 50 years of age. So the ACR criteria actually it's a classification criteria used for research purposes. So it includes the age of onset as less than 40 years and claudication of the extremities, decreased pulsations of one or both brachial arteries, and difference of at least 10 millimeter mercury in systolic blood pressures between the arms, and bruit over one or both subclavian arteries or the abdominal aorta, and arteriographic narrowing or occlusion of the entire aorta or its primary branches, which is not due to arteriosclerosis, fibromuscular dysplasia, or other causes. So if a patient is having 3 out of these 6 criteria, arthritis, but it is not a diagnostic criteria, it is a classification. When we talk about the epidemiology of Takayasu arthritis, we can see it as the name implies, it is more common. It is originated from Japan, like it was found the first patient was found in Japan, and it is commonly seen in other countries like China, India, and Southeast Asian countries. And the median age of presentation is 25 years. The commonest presenting campaign is the claudication of limbs. It's more in arms than the legs, and also reduce or absent pulsations and carotid bruits. And also there can be hypertension as a result of involvement of the narrowing of the aorta as well as the renal arteries, and carotidynia, light headache's, and asymmetric arm blood pressures. As I mentioned previously, bruits are found in the carotid arteries, but it is not restricted to the carotid arteries. And you can find bruits in supraclavicular, infraclavicular, abdominal, and femoral areas. Also, patient can present with constitutional symptoms and musculoskeletal symptoms. As it you all know, it's the systemic inflammation is involved here, and few patients also can present with no signs of vascular insufficiency, such as claudication. They might also present only with a history of pyrexia of unknown origin. Because of the aortic root dilatation, 20% of patients can have aortic regurgitation. And also due to the involvement of osteal lesions, some of the patients can manifest coronary arteritis. When we come to the investigations, first you all know the inflammatory markers elevated like the ESR, which is commonly elevated, and also the CRP. And there can be anemia and hypergammaglobulinemia as a response to the inflammation. And also, sometimes you might get a thrombocytosis. What are the investigations, what are the imaging modalities available? One should confirm the diagnosis of Takayasu arthritis by doing the imaging. So a suspected diagnosis of large vessel vasculitis should be confirmed by imaging modalities such as ultrasound scan, CT, PET, or MRI of the aorta and extracranial arteries. So what is the best imaging modality available? The recommended first line in imaging modality is the MRI to evaluate the neural inflammation, or as you all know, Takayasu arthritis involves the younger population. So MRI is a technique without exposure to radiation, so it is preferable. And also, besides MRI, enables the assessment of vessel wall and luminal changes, which are both relevant for Takayasu arthritis. And also, in one study, they have shown that it has a sensitivity and a specificity of 100% compared to conventional angiography, which has used as a reference standard. This diagram shows the narrowing of isthmus of the aorta and as well as the abdominal aorta. This is a MRI angiogram of the aorta and its branches. What are the drawbacks of MRI? Actually, in this our setting, the availability of MRI is the most important restriction, as opposed to we find it easier to get a CT angiogram done. And in one small study, it has been shown that the CT angiogram also has sensitivity and higher sensitivity and specificity for the diagnosis of Takayasu compared with the conventional angiography. This is a cross-sectional view of the CT contrast enhanced CT scan, and you all can, if you all can appreciate the vessel wall thickening, which is shown in this diagram with the arrows. And also, PET-CT is an alternative imaging modality in Takayasu arthritis, but it is also not freely available in our setting. And ultrasound scan has limitations in assessing the thoracic aorta, but you can assess the carotid arteries, the narrowing of carotid arteries, using an non-invasive, freely available method such as ultrasound scan. CT scan also used commonly, an advantage of assessing the vessel wall as well as the luminal changes. However, when it comes to conventional angiography, it is not recommended for the diagnosis of Takayasu arthritis because there are other modalities which are non-invasive and available in the setting. And also, conventional angiography does not provide any information about the vessel wall morphology, although it shows changes of the, it shows luminal changes. In fact, the main indication for conventional angiography in large in Takayasu arthritis is as a part of vascular interventions such as balloon angioplasty or stenting. In certain situations where clinical and laboratory parameters are inconclusive, we could use imaging in the management of patients with Takayasu arthritis. And is considered as the first line. The primary choice between these modalities depends on the clinical situation, local availability, and the expertise. And in patients with Takayasu arthritis, MRA and CT angiogram is used to assess the long-term monitoring of structural damage. For instance, we could assess the degree of stenosis annually if we using MR angiogram, but it is not used as a modality of assessing the disease activity routinely. With this, I would like to bring your attention to the 2018 EULA recommendations for the management of Takayasu arthritis. First, I would like to highlight few definitions. Active disease is considered as the presence of typical signs or symptoms attributable to Takayasu arthritis, which I have described before, and at least one criterion from either current activity on imaging or by resulting detected by imaging. So, corticosteroids are considered as the first line of therapy to begin with. And if there is active disease or a major relapse, high dose corticosteroid therapy, such as 40 to 60 milligrams per day uh, of prednisolone or equivalent, should be commenced immediately for the induction of remission in activities. Once the disease is controlled, uh, then you would tail off glucocorticoids to a dose of 50 to 20 milligrams per day. If the patient is stable on that particular dose, you can reduce the prednisolone dose to less than 10 milligrams per day. Uh, in fact, there are no studies comparing different regimes of glucocorticoids tapering protocols, but the guideline is recommending a dose of 40 to 60 milligrams as the initial dose. Yet, if the disease is more localized, involving only one segment, then a lower dose of glucocorticoids, such as 25 to 30 milligrams per day of prednisolone, can be initiated. Along with glucocorticoids, it is recommended to start on conventional DMARDs. However, there is no strong evidence for conventional DMARDs in CSRRSL. There are some uncontrolled prospective and retrospective DMARDs. Out of the DMARDs, the methotrexate, leflunomide, mycophenolate mofetil, azathioprine, and cyclophosphamide is recommended. However, since it is a disease of affecting young female population, regimes, drugs such as cyclophosphamide are not recommended as the initial treatment because of its gonadal complications. Despite overall low quality of evidence for DMRs, it is recommended as an adjunctive treatment with the conventional immunosuppressive discussed in the 2018 EULA recommendations. Phase 1 is the commencement of glucocorticoids at a dose of 40 to 60 milligrams per day and tailing it off, as I have mentioned before, along with the conventional synthetic DMARDs. How are we going to treat a relapse? As I said, if the patient relapse, if it is a major relapse, then we should initiate the corticosteroid dose as of a new patient and a new presentation, initial dose of 4 to 6 milligrams per day. In the case of minor relapse, we have to initiate the dose which has been least effective for the patient. Also, we have to consider modification of the adjunctive therapy if the patient relapse. Also, we might have a scenario of elevated inflammatory markers without other evidence of active aortic inflammation. So in that case, we always should find the causes for find other causes for elevated inflammatory markers such as infections, and they should be ruled out. If all other causes have been ruled out, then wall inflammation. Six inhibitors. We
can't see the presentation.
Screen has gone on.
sorry for technical. These recommended line therapies are the TNF alpha inhibitors or the IL-6 inhibitors, such as tocilizumab. And this is one. In this trial, they have this trial had been done in Japan. It's a double-blinded study comparing the interleukin-6 inhibitor tocilizumab with a placebo uh, in a patient population who had been induced into remission using glucocorticoids therapy, and the primary outcome they have measured is the time for a relapse. So in this study, they have the tocilizumab had almost met the primary outcome, even though the p-value is slightly above the cutoff. So in this is a study which a randomized trial using tocilizumab. The p-value is not so much convincing, yet the guideline is recommending tocilizumab as a label trial, which they have studied infliximab for the management of as a second-line therapy. So the phase 2 therapy involves the commencement of tocilizumab, the IL-6 inhibitor or the TNF alpha, along with the glucocorticoids starting dose of 40 to 60 milligrams of prednisolone. Then once the patient is in remission, we can taper glucocorticoids, and after some time we can taper the biologics as well. What about antiplatelet therapy? So as you all know, there is active aortic inflammation and narrowing of the large arteries. But however, antiplatelet therapy or anticoagulant therapy should not be routinely used for the treatment of arthritis unless there is a compelling indication such as coronary heart disease or cerebrovascular disease. But in certain situations, such as if there's vascular ischemic complication or high risk of cardiovascular disease, these might be considered on individual basis. So in view of the low level of evidence, a vascular team should the patient to vascular team, they also might have a place in deciding the antiplatelet therapy, depending on the degree of vessel stenosis. What are the surgical options for the management of arthritis? In fact, undertaking a surgical intervention in patient with active disease is not recommended, as there is evidence of rupture. So any surgical intervention should be done in a state of disease remission. So endovascular interventions such as transluminal angioplasty and stenting are most commonly undergone in short segment arterial stenotic lesions, but not for multiple lesions. So It's a multidisciplinary approach. So every patient should be referred to a vascular surgeon to get their opinion about surgical intervention. This is a diagram of subclavian steal syndrome. What is described here is the proximal narrowing of the proximal subclavian artery, proximal to the vertebral artery, and there is compensation from the contralateral side. So this is the subclavian steal phenomenon. If this phenomenon is overwhelmed, there is cerebral ischemia. So it is an indication for surgical intervention. So how are we going to monitor the disease activity? Should be first based on the symptoms and the clinical findings, such as looking for a new bruit, and also the inflammatory markers. And there is a risk of relapse during the tailing off of steroids. So the follow-up visits should be frequent as every 1 to 3 months during the first year. And once the patient is in remission, we can reduce the frequency of follow-up visits. And as I said previously, routine imaging for disease activity assessment is not recommended. However, to assess the degree of vessel wall stenosis or aneurysmal dilatation, structural damage, we could use imaging modalities depending on the availability. PET scan is not freely available to us, but I would like to talk about it because there is evidence to be for PET to be used as a.
Suren, can I interrupt for a little bit? Gunendra,
Yes.
madam,
Yes.
I think wants to say something. I'll unmute you, madam. Madam, you would
Yes,
have to
Shivanti.
unmute your. So Gunendrika, madam, seems to want to say something. Madam, you'll have to unmute yourself and speak.
No, I don't.
Yes, Shivanti.
Shiranti, I don't.
You have raised your hand, but
No, madam. No, Shiranti is something. No. Yeah.
right. Okay.
Okay. Carry on. Yeah.
Go on.
All right. Okay. We'll continue.
Yes.
Yes, I would like to talk about PET because they have mentioned about FDG PET scan as a imaging biomarker because it shows the vascular inflammation, the evidence of vascular inflammation during clinical remission, which is associated with future clinical relapse. So it can shows this. It shows these hot segments. So it can be used as a potential imaging biomarker, probably in the future when we have the facilities to do PET scanning. But the drawback is the unavailability of the PET scans. And also there are novel biomarkers of Takayasu arthritis, which is called tissue TIMP, tissue inhibitor metalloproteinase 1. This is a trial done in 2019. It is a specific biomarker for Takayasu arthritis patients. So, in conclusion, in fact, this is the first case of a patient of Takayasu arthritis diagnosed in 1830, but this patient had presented with reduced brachial and radial pulsation. This is before the diagnosis of Takayasu arthritis, before the invention of Takayasu arthritis, and it is founded by Prof. Mikito Takayasu in 1908, almost a century after the first patient. And the diagram onto your right hand side shows the coronary anastomosis in the in the retinal vessels, and this credit goes to Takayasu, who is an ophthalmologist who found who later on found the disease. So
Sorry, there was another break. We are not off. Actually, there were a few breaks in between, but you didn't miss anything because it was noticed from this side, and we started from the whatever it was at that level. So don't worry about those breaks. Anybody having a question, you can type them on a chat and send across so Chiran can read them out. Or anybody want to speak, you can go to the participant list, and bottom there is something called the hands up sign. So put that, so Chiranti will unmute you and can ask the questions if there are any questions. In the meantime, Chiranti, I think we have already one question.
Yes,
Questions. Can you read out? Can you
yes, sir.
tell us what the question is?
The question is, what was the dose of?
Chiranti, can you hear?
Yes, I can hear. Can you hear me, sir? Hello,
Yeah.
can you hear me, sir?
Yeah, sure.
Yeah.
Yeah.
The question is, what
The
was
dose of tocilizumab, is it?
tocilizumab? And the second part.
Yeah,
of
can hear.
The second part of that question is, sir, EULA guidelines suggest the use of TNF alpha blockers 2 as second line. Your opinion on it?
Right.
the dose of tocilizumab is 8 milligrams per kg, and TNF alpha inhibitors and IL-6 inhibitors. There are no studies comparing both TNF alpha and IL-6. So they don't recommend one over the other as first the second line treatment, but they recommend both TNF alpha plus IL-6 inhibitors as second line therapies. There are no trials comparing both. Head-to-head trials are not available.
The dose is for 8 milligram per kg. How many do you give? Monthly?
Monthly.
Until remission.
Until remission. Right. Okay. So, Chiranti, the question was that it's in EULA, it is recommended as first line treatment, is it?
No, it's a second line. Second line and the opinion.
Chiranti, can you hear?
Yes, sir. No, the question was on the recommendation.
Second line.
On
So
second
both
line.
are recommended as second line.
Yes, yes.
Okay, right. Second, actually, both are there, so both can be used as some of the individually different trials have shown. I think. Okay.
Yes.
Yeah.
And
Any other questions there, or anybody else want to speak?
Monica Madam has a
Any
comment.
hands up?
Monica Madam has a comment, sir. Madam, if you can unmute yourself and you can join the discussion.
Yes.
Hello. Hello.
Yes, Madam, we can hear you.
Few years ago,
Yes, Monica.
one
You
thing
can.
of
Yeah.
meeting
You
actually
can
those-
talk now. We can hear.
Yeah. Few years ago, they in the APLA meeting actually they suggested to use 3 doses of tocilizumab and then to start on MMF for like first line treatment, severe tocilizumab, like hit and run, 3 doses monthly and then MMF. But probably after that study didn't show statistically significant results. I think now it's not there, but we started in a patient who came with like severe AR, and that patient we started that with that also inflammatory markers came down, and the patient is on MMF, but now it's like second line only they recommend, isn't it?
Yes, madam. Now they have recommended biologics, either TNF alpha or IL-6 inhibitors, the tocilizumab, as second line. As first line, corticosteroids and adjunctive therapy with DMARDs.
Okay, what is the best investigation?
So there may have been some trials, Monica, I think.
Got
isn't
it.
it?
Right.
Any other thing, Monica? Or anybody else?
So there's another question on imaging. Which is the best imaging modality, CTA or MRA?
Yeah, the best would be MRI, but it is not freely available. So that is why we go to CT, because there is no radiation exposure in MRI. So if it is available, that should be the one we should do.
And PET scans are available here at NHSL, but it will be difficult to get that PET scan.
Got the answer? Anything else?
Yeah, we actually to our second patient we have requested a PET scan. She underwent that. We didn't get the reports yet from NHS.
I think still the question of how long to treat is still nobody knows. No? That's the main issue with these young patients who, when they will stop and come, we don't know.
So if the patient is not responding to IL-6 or TNF alpha inhibitors, then what we can next is causing doubts. They have not recommended.
Any other questions? Anything else, Chiranti?
Yes, so there's another question from Dr. Kusala. Out of the mentioned DMARDs, what is the best? And are there any head-to-head trials comparing the DMARDs? So I hope you could hear me, sir. So there's another question. Everyone, there seems to be a connectivity issue from RRH. They're still trying to connect, so we can keep the questions coming, and hopefully they'll be able to connect soon. While we wait for Dominda sir and the others to connect, maybe Monica madam or someone else could answer the question, if anybody is happy to answer that question. The question was, out of the mentioned DMARDs, what is the best, and are there any head-to-head trials?
Actually, we don't know about the trials, but I think with MMF is better than MTF. There was a thing like that. I'm not sure about that, but we start MMF initially unless there are contraindications like young females wants to become pregnant.
Right.
So
I think I think Dominus is still trying to connect, and if Gunendrika, madam, or anybody else wants to add any comments to that, madam.
and I have a question. So transaminitis, usually that's common with tocilizumab also, but these patients probably didn't get transaminase elevation with tocilizumab.
Sorry, madam.
No, transaminitis. So it's a side effect of tocilizumab as well, but probably these patients didn't get elevation of transaminases with tocilizumab. These three patients, all these three had elevation with MTX and azathioprine also.
Yes, madam. I think Dominus sir has just connected.
We are back. Yes, Monica, what's the question?
No, transaminitis is common with MTX, not with tocilizumab as well, but probably these three patients didn't get elevation of transaminases with tocilizumab.
No, yes, Monica. No, so far, no. We have given actually 2 doses to each patient. So after that, we didn't see a transaminitis in any of those patients.
Do you have to continue this on long term or to convert to MMF or MTX after several doses?
MTX, of course, we cannot, but tocilizumab, what they say is when the patient is in remission, so we can continue with MMF.
Okay.
So there is another question from Varney. This is regarding a child with Takasu's with coronary involvement who's currently on tocilizumab and being tapered off steroids. And the question is when to tail off tocilizumab.
Well, I don't have the offhand guidelines, but like, I mean, for these adults, what they say is when the patient is in remission, we can stop it.
Right.
Giving a maintenance dose of something else.
Yes.
So we need something for maintenance of a conventional disease modifying.
Right, sir. So if the inflammatory markers have sort of never been really that elevated, how can we monitor the patient, sir?
Mostly the symptoms, like, I mean, it is not only the inflammatory markers. When we diagnose a relapse, there are some criteria. One is symptoms. Symptoms means the patient, what patients complain, as well as the features, like the signs, the blood pressure difference, and the claudication. Everything comes.
Right. And imaging, so how often would you repeat it to monitor for progression or response?
Routinely they don't recommend unless it is really needed, especially if it is going to be CT, they don't recommend it. But if the MR angio is available, you can do it more frequently. But still, as a monitoring tool, they don't recommend imaging.
Probably when the PET scan comes on, I think probably that could be a better monitoring thing, but I don't think it's been established yet as that.
Right, thank you.
Anybody else? Any other questions?
At the moment, there are no other questions on the chat.
Yeah, nobody's putting hands up. So yeah, I think we'll end the session now. I would like to thank both Duminda and Suren for the excellent presentation. And hopefully we had few technical hiccups. That is from this end, we have a little bit of sudden disconnection. But as I told you, we noticed from this end, so we have not. I don't think you missed any of the part of the presentations, and hopefully everybody enjoyed and about without much of a technical difficulties. And I would like to again thank Chiranti for hosting this and giving this idea to do it. So we are hoping to have another next one on 19th of June, in Friday. Dr. Sajit Trailangantilaka and Dr. Angela Vijayaratna will be presenting on that day. And maybe by July, first Friday, it will be again the usual presentation if things settles down. Else, we will have that one also on in July first Friday, and thereafter as the usual. If we have problems, we will be doing it on this. So you can send any comments on our WhatsApp group if there are any technical details or anything that we can improve on this, because we'll be doing at least one more or maybe two on in a Zoom. So Chirantu hopefully will be up to that and can help us that
Yes,
time
sure.
also.
Sure, sir.
Right. Okay. Thank you everyone for participating.
Thank you very much.
Thank you, sir.
I mean, not